All right. So good morning, everyone. I'm Jesse, fourth year ortho resident over from Naval Medical Center, San Diego, presenting on spine infection this morning, in particular, how to approach it systematically and go over some of the more controversial topics out there in the literature as our management principles continue to evolve. Four major pathologies I wanted to cover: vertebral pyogenic osteomyelitis, or VPO, spondylitis, which can be synonymous. However, it's more of a specific entity on the spectrum of osteomyelitic conditions, epidural abscess, and then one of the more devastating operative complications and what can be technically challenging to treat, surgical site infection. Given the longevity of the San Diego Spine Foundation, I'm sure you've heard this talk a multitude of times. So I'm hoping to just bring some new things to the table in regard to what we know about infection of the spine so far. So starting from the beginning, back in the 1600s, it was first proposed in cases of spine fracture with paralysis that surgery could be performed to remove bone fragments, also while repairing the injured spinal columns with concrete back in the day. They used the traction bed by Hippocrates and refracture or reposition the fractured vertebra, and then they used a red hot iron poker to do surgery. They, however, began to lose patients to infection after these operations, and spine surgery made slow headway thereafter. So it wasn't until the late 1700s when Pott started reporting good results with flushing abscesses out with antiseptic solutions. And this kind of began the standardization of antiseptic protocols and improved peri-procedural prophylactic measures. So there was a notable increase in the number of spine surgeries performed thereafter, which allows spine surgeons to do what they do best while minimizing risk. So I think the understanding pathophysiology is critical in the prevention and treatment of spine infections. So the three main pathways we all know about are direct inoculation, so related to trauma or surgical contamination typically. Second one is contiguous spread from a wound dehiscence or an abscess, for example. And then hematogenous seeding to end plates and discs from a remote source. And that's theorized to occur from a valveless retrograde flow from the pelvic region, typically to the perivertebral venous plexus. Why does this matter? Extension or sequela of infection from the body or disc into the canal can result in meningitis, abscess, neural impingement, and can even be associated with infarction of the cord. And then furthermore, kyphosis and spinal instability due to destruction of the disc related to infection and compromise of the stabilizing posterior structures can occur. And obviously this is altering your operative decision-making. So starting with pyogenic vertebral osteomyelitis is the big one. With increasing life expectancy in general, the incidence has increased to 2 cases per 100,000 annually. The most commonly occurs in the L spine, as will be a theme in most infections in the spine. And here is demonstrating an L3-4 disc space narrowing and plate irregularities, which can present as early as 1 week into infection, even on radiographs. And so in the absence of prompt diagnosis and treatment here, you can have disease progression that manifests as end plate erosions and subsequent loss of disc and vertebral height. So MRI with gadolinium contrast is gold standard imaging modality here. Sensitivity specificity in the high 90s. So here are exemplary images in a 36-year-old female IV drug user. We're seeing marrow edema in the L2 to 3 vertebra involving the end plates, also with fluid signal within the disc itself. And this is in combination with minimal enhancement and no liquefaction on the post-contrast imaging. So all suggestive of discitis osteomyelitis picture as compared to an epidural abscess, which we'll get into later. Of note, this destruction and involvement of the disc space differentiates this from tumor, where those features are rarely present. This axial image here on the right just also highlights the ease with which extension into the adjacent soft tissue can occur, such as in secondary psoas abscess, which I'll also touch on briefly. Getting into some of the literature regarding the advanced diagnostic workup, in addition to MRI, arguably the most critical factor in guiding treatment is identification of an organism. So the first thing we always think about is blood cultures prior to administration of antibiotics, and ideally when the patient is febrile for optimal accuracy. However, it has been reported that only 1/3 of patients will have positive cultures. So the next consideration is CT-guided aspiration. And so that's a very valid option when those are negative. This is a case control study. It just came out looking to identify the best lab and imaging factors to predict bone biopsy culture positivity, ideally to identify the patients that would benefit from it. And so they retrospectively reviewed 46 patients who underwent the biopsy in clinically confirmed osteo cases, measured the inflammatory markers, and then looked at the attenuation of biopsy vertebral bone, which is theorized to be due to destruction from the infectious process, comparing to unaffected bone, and found that 2 things: the delta CT attenuation, as well as a CRP grossly above the upper limit of normal were the strongest clinically significant predictors for bone culture positivity. So just in conclusion, has utility in identifying those patients that may benefit from a biopsy in culture negative situations. While the mainstay of treatment is non-operative, the threshold for operative intervention in this case is very low when red flag features are present. This is including but not limited to cervical pathology, neurologic compromise with progressive deficit, progressive deformity or gross spinal instability, large abscesses, or failure of medical treatment. There's lots of debate on technique and construct, which I'll touch on, but very situational. And the gold standard in the past is usually anterior debridement and strut grafting, plus or minus posterior instrumentation, with the main goals being accurate organism identification, source control, and then mitigation and reversibility of neurologic deficits, and then finally maintenance of spinal stability. So my questions, just reviewing the literature initially, was what are the identifiable risk factors for patients that will fail non-op? What dictates timing to the OR? Are we thinking single versus staged? And then when and what instrumentation is required? This is one of the first papers to attempt to answer these questions about PVO. This is JBJS 1997 out of Stanford. The original is a single author just looking at 100 patient records. And most common source was urinary tract in this case. And most importantly, what he found was that the success of non-op treatment was predicated on 4 independent variables. So age less than 60, young people, favorable immune status, healthy people, infection with staph in particular, as it was more actionable or targetable with antibiotics, and then a decreasing ESR, so a dynamic improvement in inflammatory markers. While these are kind of common sense, it was the first time we really identified things that could guide us objectively. And so outside of the deaths during the follow-up period, the authors claim that none of the 89 patients they sought follow-up had late recurrence of infection when these were addressed appropriately. This is still on the topic of osteomyelitis. This is a case report out of Spine 2008, stimulate discussion on staging here. This is an 18-year-old female with back pain, numbness in the left thigh, found to have intractable T12 to L1 vertebral osteomyelitis secondary to an atypical mycobacterium. She had indolent progression over 8 years or so, and eventually went on to T12 collapse in the setting of a kyphoscoliosis of about 38 degrees. They measured CT myelograms, showed severe spinal cord compression in her. And so while this is complex, she did successfully undergo a staged management. So they started with posterior instrumentation to stabilize the unstable kyphotic segment there, correct the deformity, restore the sagittal balance. And this was followed later by a staged radical anterior debridement and bone grafting 4 weeks later. Interestingly, they used a rib strut autograft and then had a 39% kyphotic correction. They say she does great. 5 years out, she's free of symptoms, graft consolidated, and no evidence of disease recurrence. But this highlights the efficacy with which surgical treatment can have utility in stages. However, this I'm not sure about the order of operations. So this was another article that kind of counters that concept, or just looks at the reverse sequence of events. In this case series, patients underwent an anterior surgical debridement and fusion with bone grafting, followed by a period of IV antibiotics, and then delayed instrumented posterior fusion. So opposite order. I think this is more common, but again, obviously case dependent. They just suggest that this technique favorably restores the anterior column support while obtaining control of the infection prior to addressing the posterior aspect. They all used, the majority of cases, tricortical iliac autograft, given studies are showing that use of autograft is superior in the face of infection and thought to decrease incidence of post-op kyphosis. So they found that all patients had resolution of infections and neurodeficits without recurrence, so staged procedures is highly effective in the treatment, in particular of refractory osteomyelitis. The next question I had was whether it is safe to use hardware in active infection. It makes sense that there would be a concern about placing something that's predisposed to biofilm while there's actively an infection that you're going in to debride, especially when there's concomitant instability, and that's where it gets complex. So this is a Spine 2008 prospective observational study out of Stanford. They investigated the long-term clinical outcomes of immunosuppressed patients with pyogenic vertebral osteomyelitis. So they were looking at, I think they had 32 patients managed with single stage. So they combined an anterior debridement with a posterior spinal instrumentation on the same surgery. And their indication, it was not well specified in the paper. I think that was a argument against this paper, but they just mentioned that it was for definitive gross instability in the setting of active infection. So this was useful in answering my question. They were followed longitudinally for 10 years, primary endpoint being recurrence of local infection. And they found that 69% of patients had no recurrence over 4 years. So while not an ideal number, given the immunocompromised nature of their cohort, which was significant, it supports the general consensus in the literature that hardware can safely be used to treat patients, or at least opens up the conversation that we can consider hardware placement at the same time as debridement in single stage fashion with a low risk of long-term recurrent infection. And this is borne out and more successful in later papers. But touching on the other hot topic in osteo, the mesh cages, the bottom line overall in the literature and kind of the summary oidy one-liner is that use of titanium mesh cages effectively reconstructs the anterior column while adding stability and restoring sagittal profile without an increase in the rate of infection, either persistent or recurrent infection postoperatively. So in particular, this is favored over the stainless steel constructs for those reasons, and that's kind of standard of care. This concept is corroborated by this 2007 retrospective paper. They looked at 88 patients treated with radical debridement, titanium mesh cage stabilization, and they just found that all patients had a good bony fusion, no recurrent infection, good deformity correction, and overall just good clinical improvement on the outcome scores. So useful construct. With regard to osteomyelitis of the cervical spine, I just mentioned this as one of those kind of surgical indications until proven otherwise. This is a case series in 2016. They found
I'm with you today.
single stage.
You with me? I'm with you. I don't know what we're doing.
I'll keep going. 2016 found that single stage surgical treatment in the form of the same time anterior debridement and fusion with the titanium cages and anterior plating provided satisfactory results without increased sequela. No implant failures were noted and all achieved a good fusion. So cervical is operative, and then you can typically do it in a single stage, including hardware placement. We're nearing the end of the vertebral portion. This is a retrospective review back in 2002 out of Cleveland Clinic. They looked at 253 patients with osteo. They found that the primary adverse outcomes, so just looking at long-term how these patients do, death in about 11%, so expected, residual disability in over 1/3, which is not insignificant. And then they had about a 15% relapse rate. And the 3 statistically significant independent risk factors they found were neurocompromise, time to diagnosis, and hospital acquisition of infection, those big ones. So this is saying that 79% did well, most recovered, but this is lower than desired. So just they recommend continued optimal outcomes by maintaining heightened awareness, diagnostic accuracy, prompt identification of the pathogen, targeted antibiotics, and just appropriate prompt care when available, and being able to manage and take care of complications if they arise. All right, moving on to spondylodiscitis. This will be short just because this is largely terminology based. It's really just a component or a portion of osteomyelitis under the umbrella of spine infection. Most commonly occurs in the lumbar spine and typically only involves one disc the majority of the time, but only 20% of patients are experiencing neurodeficits. So a smaller proportion, still 1/5 of patients have neurodeficits, which is huge. So it's something to be aware of. Not a lot of specific literature on this disease process in particular by name, but this is one of the landmarkish randomized controlled trials that came out in 2014 from Bernard et al. They looked specifically at duration of treatment for patients with the spondylitis discitis component of PVO. And this was just designed for, or the reason for doing this paper was that everything was previously based on anecdotal or expert opinion, and they wanted some concrete data to support their antimicrobial protocols perioperatively. So they found that 6 weeks of antibiotic treatment is not inferior to 3 months with respect to the proportion of patients who were cured or had eradication of infection at 1 year. So they're saying both treatment regimens had similar mortality, relapse, failure rates. So 6 weeks is the preferable course. Obviously, less time is better, while just overall corroborating the efficacy of controlled conservative treatment of this disease process in the absence of red flag symptoms that would otherwise push you to the OR. So 6 weeks of antibiotics is standard and very borne out in the literature. Epidural abscess. So this is a collection of pus or inflammatory granulation tissue between the dura and the surrounding fat or adipose tissue. It represents one of the true orthopedic emergencies we hear about early on in residency and classically has necessitated surgical intervention. However, as we see, we're getting growing evidence that medical management is reasonable in appropriate candidates. Some rapid fire facts about abscess. Most common organism is Staph aureus. Most common origin is hematogenous spread, often associated with spondylodiscitis, up to 20% of cases. And then neurosymptoms here, whereas it's more on the order of 20% in the spondylodiscitis, it gets up to 50% in this case, usually in the form of radiculopathy or myelopathy. And it's usually due to direct neural compression or spinal cord infarction, like we talked about, and this can result in paralysis being one of the most devastating complications. So with regard to advanced imaging, as shown here, again, MR with GAD is the imaging modality of choice. It shows this, which is differentiated from the osteomyelitis. Here in the abscess case, you see a pathognomonic ring-enhancing lesion or fluid collection within the spinal canal, which delineates you from osteo. And important here is to consider obtaining imaging of the entire spine when there's clinical concern for skip lesions. So if there's an extraspinal infection concomitantly, if there's delayed presentation, if ESR is greater than 95, those are big reasons to just pull the trigger on an MRI entire spine. This also allows you to assess for the evaluation of the degree of neurocompression, which again will guide operative management. Here's another example for the imaging of a 42-year-old female. She had paraparesis, and this shows heterogeneous signal on T1 with hyperintense epidural collection on T2, as well as rim enhancement consistent with an epidural abscess. This is also causing indentation and posterior displacement of the fecal sac and cord. So classic epidural abscess, big problem, emergency, and we're mobilizing the OR rapidly in these situations typically. However, there are reasons when we can consider non-op. And so there are patients with reasonable candidacy for just a trial of culture-specific IV antibiotics and bracing for comfort. And overall, big picture, this patient, a non-op patient, looks like a young patient, less than 65 years old, small lumbar abscess, mechanically stable spine, no neurodeficit, MSSA. You can give 6 weeks of IV nafcillin with great efficacy. So that is your classic patient that you'd consider non-op. But the risk factors that we know to confer an increased rate of failure of this treatment and very much push you away from it would be age greater than 65, history of drug use, diabetes, leukocytosis, CRP greater than 115, MRSA, and then by far the strongest predictor that you need to go to the OR is presence of or progression of neurodeficit. So this approaches it a little bit differently than what I just said, what we know just kind of intuitively. And they bore this out in this retrospective review, JBJS 2018. They looked at factors predictive of failure of non-op management, like we just discussed, in 367 patients. They did a multivariate analysis to reveal 6 independent predictors. So this is just a way to quantitatively support what we already know, that patients with a motor deficit on presentation, again, that being the strongest predictor, patients with a pathologic or compression fracture in affected levels, any type of active malignancy going on, diabetes, or just in general immunocompromise, sensory changes, and then dorsal location of the abscess were just overtly suggestive that a patient would do poorly with non-op management. So this is just a concrete way to have those 6 in your mind. Overall, just reaffirms that while less invasive treatment options are favorable in certain cases, err on the side of caution and be prompt with your diagnosis and treatment and be accurate. So take the patient to the OR when they need to go. While neurodeficits and core compression confer obvious urgency to surgical intervention, instability can be more nuanced. And so especially when you have multiple factors going on. So I wanted to look at the progressive deformity or gross spinal instability and what that merits in terms of stabilization at the time of surgery. We typically, like I said, think about anterior debridement and strut grafting when an abscess is anterior, and then, or if the vertebra is involved anteriorly. as opposed to consideration for a more posterior decompression, LAMI, when there's a posterior abscess. Obviously with caution back there to avoid too wide of a decompression or a facetectomy that could confer risk of iatrogenic instability. So it's all just very proceed until tackled, but very cautious with everything we do here. An important concept also is that when non-op care fails, delayed surgery has been shown to have a lesser outcome in restoring or reversing motor deficits. So it's important, again, just when the risk factors are present, don't hesitate and be aggressive getting to the OR. So this is corroborated by this paper. This was a review out of neurosurgery. It was in 2017, and they looked at instrumented fusion, the setting of infection, primary infection in particular. They used outcome measures, including local recurrence and surgical site infection, and over 900 patients. And so the big thing here is they found an overall rate of infection of 6.3, but when you take surgical site infection out of it, the rate of infection was 1.6. And so while there's all these complications here, hardware removal for failure of the instrumentation, pseudoarthrosis, neurocompromise, all those scary things, even a high mortality rate, in conclusion, the recurrence rate after instrumentation is relatively low, again, 1.6%. So while it's important to counsel patients on all these complications that can happen just from instrumentation perspective itself in deconditioned bone, it's a risk-benefit ratio that it can be useful to just fix the patient at the time of the debridement. Quick word on psoas abscess. In atypical clinical pictures, especially with a delayed diagnosis, there should always be consideration for this secondary psoas abscess, which is much worse than the primary variant. This is a very small case series, but it highlights that while mortality rate in a primary is 2.5%, relatively low, the death rate jumps to 19, so 20% all of a sudden when it's secondary etiology. And this is often due to delayed or inadequate diagnosis, and you have the concomitant infection if we're talking a primary spine infection. But this just highlights that these should be treated aggressively with abscess drainage while targeting your antimicrobial therapy and addressing the primary infectious focus, especially in the spine, as otherwise you get this unacceptably high rate of recurrence. Okay, last topic, surgical site infection. This is surgical site infection, SSI, and associated hardware failure is obviously one of the most devastating complications we experience as in spine surgery and for the surgeons. And so incidence is about 1% in non-instrumented, goes up to 3 to 12% in instrumented fusions. The sequelae include, but are not limited to pseudoarthrosis, which can happen in 25 to 50% of patients, relatively high, chronic wounds, neurologic compromise, and even systemic problems, sepsis, or even death. And so the risk factors that we talk about, and we're obviously very aware of and aggressive preoperatively in these situations, include the patient factors, so diabetes, obesity, malnutrition is a big one. So we talk about albumin being less than 3.5, total lymph count being less than 1,500, transferrin less than 150. Those are the three things to check if you're worried about it. Smoking, age, multiplicity of operations previously, substance use, and then obviously a history of radiation therapy to that area. Those are the big ones we always talk about. So emphasis perioperatively or preoperatively on weight loss. I know I've even seen it in Dr. Islak's clinic. We're very aggressive about optimizing factors, getting patient to lose weight, getting patient to stop smoking to prevent this type of complication. And then there's also, just to touch on the surgical or technical factors that are modifiable from our standpoint to prevent this. I'll get into it, but the use of antibiotics perioperatively, sterile technique, minimizing OR traffic, minimizing OR time, those are all important factors to consider. So modes of failure of instrumentation in the setting of infection, so just talking mechanical failure, is largely biologic. We know that the instrumentation relies on the interface between the implant and host bone, which is why we know that titanium is less susceptible to that biofilm, the glycocalyx, than stainless steel. So all just basic orthopedic principles that we need to be aware of and have guided our current practice today. Pertinent lab, CRP is the most sensitive. Pertinent imaging, CT can show bone implant interface issues, lysis loosening. MRI is obviously the best modality for soft tissue, but we all know the workup, the real literature-based things to think about here with regard to more complex procedures. So the adult deformity corrections, These are longer surgeries, more spinal levels, larger blood losses. So this was a paper looking particular at the scoliosis, kyphosis, big deformity corrections. And so they retrospectively reviewed in a large cohort analysis over 10 years, a bunch of patients to assess the incidence and identify risk factors for surgical site infection, and found that by far obesity is the greatest risk factor on order of magnitude. So it should be paramount in adult elective deformity surgery that weight loss is on everybody's mind, and as well as health optimization overall. This was a 2018 paper, and I'm almost done here with the talk, but 2018 paper trying to answer whether patients can be taken off suppressive antibiotics with infected retained instrumentation. I like this paper just because they defined 4 cohorts. So 1 was patients that had removal of instrumentation, 2 patients were re-instrumented, 3 a group of patients that retained their instruments and continued antibiotics, and then 4 patients that retained the instruments and did not continue antibiotics. And the results are shown here, but they conclude that patients who had surgical site infection and presented acutely and had aggressive debridement on the operative side of things were able to retain their instrumentation, whereas patients who had a more indolent infectious course detected later and were difficult to treat required removal of their original instrumentation. And patients who did have antibiotics did better. So just very intuitive. However, it's better to treat these aggressively early, and then you're able to retain the hardware, especially in cases where there's instability or the fusion has not occurred yet, and it's important to maintain that mechanical stability. So just overarching principles, kind of second to last slide here, principles of treatment of surgical site infection in particular. It's really delineated by number 1 being chronicity, and then number 2, stability. I think those are the 2 big things we need to consider when we're talking about going back to the OR for these. So the main overarching principles, again, active aggressively, urgent surgical debridement, wound management is critical. You're getting ID on board for targeted antibiotics, and then even possibly involving plastics on a multidisciplinary level, with the main goals of treatment of this to be efficient in eradication of the infection, obviously wound healing, maintenance of that mechanical integrity of the instrumented fixation, and then viability of bone graft. So just touching on debridement, big things we know, just like trauma, superficial to deep, layered fashion, caution with your approach, scarring of the dural sac can obviously complicate this. Ensure you remove all devitalized muscle tissue, loose graft material, or using pulse lavage, typically consider antibiotic beads in certain cases. And then returning to OR, Q48 look backs for serial debridements, the key here being to be aggressive. When to remove the hardware, implants can be retained in most cases, but reasons to would be failed, so loose or broken hardware, refractory infections, consider removal, late infections. But again, the big key here is that the fusion has occurred, fusion has healed, would be your only reason that you would be able to take it out without leaving them at risk of being unstable. So the reasons to re-instrument a patient if you're taking the hardware out would be deformity progression, or when it's necessary to restore stability of the spine. So those are more complex considerations that require a whole nother talk, but things to be aware of when you are re-instrumenting or revising these patients. Be prepared to upsize your screws, go anterior if you're worried about it, always consent to go additional levels, and be prepared to extend to thoracic spine, as well as use of iliac screws. Be prepared to go big. Big things we already know about: wound closure, obviously meticulous hemostasis, layered closure, get plastics involved, multiple drains, use wound vac, just your standard wound care. And then takeaway points, overall, be aggressive. Most cases safe to retain implants, but again, get your CT scan, get your good preoperative workup to know for sure what the best course of action is. And then consider staged reinstrumentation if there's a concern for an unstable spine or progressive deformity or bone loss as well. Those are all reasons to just be safe and use instrumentation appropriately. So overall, in conclusion, last slide, spine infections are very complex, and they exist on a continuum with consideration for patient factors, surgeon factors, operative indications, degree of instability, chronicity. All those factors play a role into each individual patient and kind of guide your management despite our overarching principles in the literature. Osteo and spondylitis can be managed non-operatively successfully. However, in cases with red flags, like we talked about, consider surgery. Instrumentation has been shown in literature to be safe at the time of debridement, so it's very much a consideration to just knock it out in one stage. There's an increasing role for non-op management of epidural abscess, as we talked about, and then construct of choice is at the discretion of the surgeon. But overall, infection of the spine demands timely diagnosis and just expedient, appropriate treatment with aggressive debridement and culture procurement in patients who have failed medical management, ultimately with the goal of optimizing functional outcome. Thanks so much.
That's
Very well
fantastic,
done,
Jesse.
Jim.
Thank you so much. Yeah. Huge topic, but you hit on the highlights. You know, the bottom line is you're fighting you're going to war with an organism that you can't see, right? And a lot of times that requires us to get in there and manually debride it. Certainly the vascular nature of a lot of the places that get infected change how amenable an individual without neurologic compromise is to non-surgical management. But you know, these are patients that you don't write off and you don't forget about. You know, you have to follow them like a hawk because frequently they require a change in plan, even midstream. You know, I was telling one of the fellows I have one patient washed out 3 times, and we keep getting, you know, one culture positive, and we keep having to debride it. And you know, some of these infections are indolent and they're slow growing and they're hard to eradicate. But you know, if manual debridement doesn't get rid of it, then antibiotics will probably not do it much justice either. So stand on top of it's really important.
Hey, Greg, in that setting with 3 times of a washout, are you using like the Sustalon beads or anything like that?
Yeah, stimulant beads, and we leave them in for about we instead of doing washouts frequently, we do them about once a week, because the effectiveness of those beads, I think, is what they say, it's up to 2 weeks. So so instead of kind of doing every 2 to 3 day washouts like I did in training with the beads in there, you can I think prolong that a little bit.
You know, the other thing I mentioned a few weeks ago is the VAC system now has this installation sponge that you can put in. So you can pick like a Dakin solution or some antibiotic solution, and it'll infiltrate the wound, and you can set, you know, the time of installation, the duration of it, and then it'll suck it back out. So it uses, you know, Dr. A's continuous suction irrigation notion for these wounds. And I did it recently and it was phenomenal. You just left it.
Interesting. I did not. I must have missed that. Huh.
Yeah. So it's tremendous. I mean, I think it takes away that need to go back to the OR. I mean, yeah, sometimes you have to go back and manually debride things, but you know, having a sponge in there and the irrigation, it just continuously flushes the wound. It's amazing.
Yeah, that's really interesting. That's just made by the VAC folks.
Yeah.
How often do you change it?
We put it in, I think we changed it. We had the wound nurse come and change it at the bedside, like maybe every 3 to 5 days.
Okay.
So you're still getting sort of the rough debridement when you take the sponge out.
So what type of wound was that, Dr. Blaskowitz?
It was a superficial wound, but the plastic surgeons at UCSD use it for sort of these complex breast cases. So, you know, they have these nasty wounds and nasty chest wounds. And they've been using it for that over the past year. And they said they have great success in salvage.
Interesting.
How much fluid, you know, is it, how many cc's?
The machine, when you use it, what it'll do is it'll instill, you know, fluid till it gets to a point and it senses that the wound is saturated with it. So it'll say
Does.
60 cc's, and then you can set it how many cycles you want of that per day. Do you want it, 6 cycles, 12 cycles, and then it'll do it at whatever rate you want.
So it's intermittent suction. It's not continuous.
Yeah. I mean, you could fill the wound, suck it back out, fill the wound, suck it back out.
Yeah.
It just depends on the frequency at which you want it.
Interesting.
Awesome. Any other comments?
Just great job, Jesse. Thanks for that background lit review and discussion on this variable topic. You'd like things to be nice and algorithmic for you. And as everybody's discussed, these spine infections, we really have to treat these a lot of patient dependent factors. So thank you for your time in preparing this presentation.